This is one webinar which was organized by Kankids and NHM, National Health Mission uh, organization, on 20th of May during Retinoblastoma Fortnight Week uh, in 2025. And I had the responsibility to speak on approach to a child with white reflex and retinoblastoma. So essentially, this was attended by all healthcare providers, that is doctors at CHC, PHC level, who were to be sensitized for retinoblastoma so that an early referral and a chain of facility could be provided from grassroots level up to the apex centers. So first of all, I should pay my tribute to my mentor and my teacher and my guide, Dr. Deepak Kumar, who introduced me to this particular disease. And he, along with Madam Dr. Archana Kumar, used to take care of retinoblastoma patients since I joined the department in 2001. And this has been transferred as a legacy to me, which I have tried enough to cater to and provide services to these patients. So this is the most common intraocular malignancy in children and 4% of all pediatric malignancy. So when we look at whole of the pediatric age group, we find that this is a minority, but when we look at the eye, this is the most common malignancy including the adults. And the disease is very bad because the survival rate is very poor. If untreated, it is universally fatal, and otherwise also if we include all the possible cases of retinoblastoma, it is only 50% survival. And this ranges from 98% survival to 30% survival, depending on the country and the socioeconomic status. It is fairly uncommon disease, 1 in 15,000 to 20,000 as estimated, and there is no racial or gender predisposition. This is the timeline how this was introduced as a disease to us, leading us to the modern times when American Ophthalmological Society in 1926 named it as retinoblastoma. Let us look at the common presenting features of retinoblastoma. So most common presentation is leukoporia, and this is what leukoporia looks like. So it's a glowing eye, just like the animal's eye glow in the dark. And then you can have strabismus, that is squinting. It can be a red, painful eye, poor vision in 5% of situations. There can be some asymptomatic patients who are actually accidentally discovered during their routine ophthalmological evaluation. Hyphema, discoloration of the iris, and this is a large protruding orbital mass, which is now rarity. Earlier, when I was being trained for retinoblastoma, it was a fairly common situation. So now this has become a rarity, and the reasons I will discuss in further slides. It's very important to understand what is white pupillary reflex and leukoporia. Rather, they too can be misjudged by several of us. And so in the left side, I can show you that this is a cataract. And we can see that there's no gap or there's no depth between the iris tissue, which is brown, and the whiteness at the pupil. On the other hand, when we look at this image, we find there's a distinct gap between the iris tissue and the whiteness of the pupil. So this is leukoporia, and this is due to reflection of light from the internal structure of the eye, and this is right at the pupillary border. And this is important to distinguish so that there's no panic induced because of a cataract. Rather, and at the same time, no case is missed with leukoporia or suspected retinoblastoma. Natural history of retinoblastoma is like it is a rapidly progressive tumor, and within 8 to 12 months, the patient will have distant metastasis, and it will destroy the glow within 6 months. Metastases are common to the brain through the optic nerve, and then you can have a very rare situation known as retinoma. It's a complete tumor regression. That's very extremely rare. And I can cite that I have seen two such cases in my life where adults aged 15 years, 20 years were reportedly seen having white tumor in the fundus with no other problem. and this can ultimately lead to thysis bulbi, but these two situations are extremely rare. Now, understanding the progression, the presentation, and what we can offer to these patients at our tertiary care center at KGMU department. So we'll take help of our case report. And this is a 3-year-old male child presented to us with a large protruding mass in the left orbit with progressive diminution of vision in the other eye. The left eye, which had a protruding mass, there was a white pupillary reflex seen at the age of 2 years, and now the age was 3 years. So it was 1 year which had gone by for the tumor to enlarge from inside the eye to orbital mass. And this was an advanced disease due to delay in seeking medical care and reluctance for follow-up referral, nearly 1 year latency, as you can see. So this was the clinical finding, and in the OPD we can see that the child had a large orbital mass here, and the other eye is still to be evaluated. And on PUA, which is a standard operating procedure for these patients, the first you do an examination and anesthesia to decide what is the staging of the retinoblastoma. So it was a group D retinoblastoma in right eye and group E with orbital metastasis, rather stage 3 in the left side. So in our radiological evidence, there was orbital metastasis in the left side, but there was no intracranial optic nerve invasion. In the right eye, the tumor was not as large that it would be radiologically visible, but it was seen on EUA. As you can see this, it's a condensing lens of the indirect ophthalmoscope, and the image is captured using a mobile phone. We can see there's a large tumor. The image is basically inverted. The disc is on the nasal side, and this is further nasal, a tumor in the nasal part of the eye. And this is a large tumor. There are vitreous seedings seen, and the macula was relatively spared. However, there were some pigmentary changes which would indicate that the macula is not healthy. So in this situation, we give 4 chemocycles at 1 month interval, and this will progressively reduce the extraocular tumor burden. And at the same time, each month we do a UA, and along with that, because this case had an intraocular tumor in the other eye, which was large with vitreous seeding, intravitreal chemotherapy was given as intravitreal injections. So this is the second examination where we can see the tumor has regressed because of the ongoing chemotherapy. And this is after the 4 cycles of systemic chemotherapy. We can see the left side orbital tumor has completely regressed. It is now in the orbit, and the left side was to be enucleated further. And this was the enucleation histology, and we can see that tumor has necrosis and there's calcification. The optic nerve was free of the tumor. And this is the other eye which had received multiple intravitreal injections of chemotherapy. And we can see that the tumor has regressed, which was seen on the nasal side of the optic disc. And it is now translucent, which is a sign of treatment death, tumor death, and we can see calcification. There's near total absence of vitreous seeds. We are seeing these specks of calcification, which are left behind after the tumor dies. And right now, the patient's right eye had ambulatory vision as evident by VP and patient's behavior. However, visual acuity in true sense could not be assessed. So this was one situation where we could see the management of orbital metastasis stage 3 tumor along with the eye which has a group D tumor, and we could save the eye, the vision, and also the life. And we'll just see that how we have been doing about retinoblastoma since last 10 years. So KGMU in past 10 years, and at that moment, the India and the other developed world, we had this kind of difference. So the latency was nearly same. However, the gender ratio when compared to India was same, but otherwise it is different from the rest of the developed world, and it is bilateral, and laterality is equally uh, symmetrical in all the situations. However, when you look at the extraocular spread, you will find that we had presentation of 41% as extraocular spread. However, in developed world, because of awareness and proper referral system and availability of healthcare system, it is only 1.6%. And mortality likewise has is rather huge in our setup, which is compared to the developed world, it is only 3 to 5%. And these two things are interlinked because when you have extraocular spread, especially intracranial spread, the mortality is inevitable. But if we compare this to the present situation, we find that things have improved. The age at presentation has not changed. The latency has rather increased. The gender ratio has not changed much. The bilaterality has not changed much. However, if we see here, we'll find that extraocular spread presentation is now rare. And as such, I called not only the awareness has improved so that we get earlier presentation, we also have better mortality, and we'll just see what has caused this. So now at present, we can see that it is 90% or more than 90% survival for our patients. So there's a lot of scope for improvement because we still are not at par with the developed nation in terms of survival and also retention of globe and vision. Mainly, we have concluded that delayed presentation and subsequent poor prognosis of life and globe salvage is the reason for our poor results. And this is attributable to lack of awareness among general masses. People just don't know what is retinoblastoma and what is the meaning of that white pupillary reflex. Poor referral system, there's no confidence in the patient where he has to go and what will happen next. And there's always a fear in the guardians when they are told that the tumor has destroyed the eye and vision potential, and this eye has to be removed for saving the life. And we can also have this last point neutralized if we can shift the management goals from life salvage to globe salvage and vision salvage. And this can be done by use of intravitreal and intraarterial chemotherapy treatment modalities, which are still not used to optimum levels because of various reasons. So what we need is nationwide awareness at the public health care workers so that there's grassroots level awareness which is spread to contacts and person to person. Optometrists, pediatricians, ophthalmologists, they all can play their role. And there should be a robust referral system with tracking and persuasion of guardians. Early diagnosis management, if we have improved healthcare facility at CHC, PHC level, so that few of the procedures which can be done there. Counseling of parents at the time of encounter with the medical personnel, and we should have more investment in developing advanced globe preservation treatment modalities like intraarterial chemotherapy and intravitreal chemotherapy. And the presentation will not be complete without acknowledgement to my postgraduate doctor team, which is always available for these patients, and the Department of Pediatric Oncology, Dr. Nishant Verma. Thank you.